Pharmacogenomics is the study of how our genes and medications interact with one another. And so when we think about how historically medications have been dosed, you can use a medication, or a physician will prescribe a medication to a patient based on a number of studies that have been done over several years of practice, several years of research. But what we understand about medications historically is that use a certain medication or a certain dosage of medication to treat a population or a certain disease state. Precision medicine, in which we really focus on trying to understand what the genes tell us about how our body works and how our bodies break down medications and how our bodies transport and get rid of medications.
What do genes have to do with how our body processes medications?
Sure. Our genes are generally responsible for doing something in the body, right? When any of our genes, any of us have a gene that ultimately usually produces a protein or tells our body to do something. We call that pharmacodynamics. That's how a medication affects our body. And we expect that it does something, but we also know that sometimes it has side effects. Our bodies don't want medications to be there, and so ultimately we'll take that medication and try to get rid of it, try to transform it, try to change it, break it down, get it out of the body ultimately. And so that process is called pharmacogenetics. And so the combination of the two, pharmacodynamics or pharmacogenetics, is ultimately what we understand of how medications are dosed, how they're used. Our bodies will take a gene, the gene will make a protein, the protein does something. Either it breaks down a medication or it transports a medication. And so ultimately those processes are all wrapped up in this pharmacogenomics process.
So I have heard both the term pharmacogenomics and the term pharmacogenetics, and they seem to be used interchangeably. Does it mean the same thing, or are there differences between those two concepts?
Pharmacogenomics and pharmacogenetics are oftentimes interchanged. We casually just interchange them all the time. There is a formal difference between the two. When we talk about pharmacogenetics, typically the focus is on a single gene or a single drug gene interaction. So we might think about how an enzyme or a protein breaks down a medication or transforms a medication. So we might take a pain medication, for instance, and understand how one of our genes is responsible for breaking down that medication. That single drug and single gene is really, we would call formally, pharmacogenetics. Pharmacogenomics, anytime we put the term omics on the end of a word, so we might say genomics, pharmacogenomics, proteomics, etc., that term really means that we're talking about large data sets. We might talk about multiple genes. We might talk about a gene panel. But ultimately, it's responsible for many genes and oftentimes many different medications or many different outcomes or disease states. And typically, omics requires the use of computing, high-powered computing, in order to understand all the makeup and all the interactions between those many different parts.
So when we look at our genes and how our bodies process medication, is there usually a one-to-one correlation with one gene being responsible for one medication?
Oftentimes, no. Straightforward. There are many different genes and many different processes that are all responsible for how our bodies break down and clear and get rid of medications. So oftentimes, no, it's not just one it's not just one particular gene. It's a combination of many different things. However, the data does show us, and years of research and years of clinical practice have shown us that many times there are some medications that do have a single, more predominant gene that will affect its metabolism. And so when we look at these medications in clinical practice, and the guidelines that we have for these medications, oftentimes there will be certain direct pathways, certain genes in particular for certain medications that are most predominant and most profound. The alternative, or the other way of the opposite effect, is that we have many different genes that we know of, And so oftentimes it's not just a single gene that we have to focus on, but many different genes. And so oftentimes in clinical practice, we will run a panel of different genes and different genetic tests that will help us to understand how many different medications actually interact with our bodies.
So does it work the other way? Can my medications affect the way my genes work?
There are times in which medications can affect how our body processes work and can affect, so if we expect that our genetics tells our body to do something, there are some times where certain medications, certain interactions can come in and kind of short circuit that process. So really changing the way that we would normally expect that process to work, the way that we would expect our body to break down a medication, there are some times in which some of the medications we take can interact with that and actually change how that process works.
Can you give us an example of a medication where my genes might really affect the way that medicine works for me?
Sure, I can give you a couple. But we'll keep it brief. So we'll start with a pain medication. So we're all familiar with opioids or medications. They're strong medications that are used for pain. The opioids, especially codeine and tramadol, which I think many of us are familiar with, are medications that are again commonly used for pain. These medications in most people, about 75% of the population, or 3 in 4 individuals work just fine. We would call these people normal metabolizers. They break down or they metabolize the drug appropriately. However, there is a certain percentage of the population that will either break down the medication or change the medication, or metabolize, we would say, too fast or too slow. And when that happens, that can either lead to toxicity with the medication, so we'll have side effects. Usually that's it slows our respiratory or our breathing rate, or we can have certain cases in which the drug just won't work at all. And so either one of those conditions can work at any given time. There are literally dozens, if not hundreds, of these examples that we can point to with certain medications, but that is one that I think most people would probably be familiar with.
Thank you so much. It's been great talking to you.
Oh, thank you so much. It's a pleasure to be here.
So I know that you are a cancer researcher in a very fundamental way. How does pharmacogenomics and pharmacogenetics play into what you do?
From a perspective from research, we have kind of knowingly given patients across the spectrum the same drug, understanding that many of them will be responsive or non-responsive to those therapies. Because you and I are different in our DNA, in small ways, we can actually predict a little bit better now responses to given both chemotherapies as well as many other kind of standard therapies. Based on our DNA structure. From a research perspective, we are continuing to understand that. Some of them are very well known to certain chemotherapy drugs, but others are just beginning to be understood. And as we get more and more patient data, and patient data is the key thing. Okay, you had a really good response to therapy, or you had a really bad adverse reaction to a drug. Many of those things are predictable now, based on what our genetic code is doing for a given drug. And so it's becoming much more practical to actually starting understanding what drugs should be given or shouldn't be given, probably more importantly, to patients based on that.
So now, is that a difference based on my own genetics, or is that a mutation in the tumor that you're dealing with?
So there's two different aspects. In tumors, we know that they respond to therapies based on their mutational code. But for pharmacogenomics, it's actually your normal DNA. We've known for a long time that cancers it's basically a mutation in that has caused that cancer to grow abnormally. It should be growing normally. But those are very different. Those are different than what we're looking at for your ability to respond to it. Your normal cells responding to a drug versus your cancer cells.
Is there a role in treating your cancer for testing the cancer's DNA?
Yes. Our ability to go through the entire cancer genome, which took the first time they did it over 10 years in about 2 hours, has been one of those things that are called accelerators that allow us to be able to really detect that. So currently we are just open a protocol that every patient with cancer or precancerous lesion will have access to having their whole genome,
Their own individual genome.
their cancer genome,
Their cancer genome.
completely looked at, and we can actually then predict response to given chemotherapy drugs based on that. But as important is your DNA. So your DNA, that's the building blocks, but it has to be photocopied. And that goes into a structure called RNA, which makes the protein, which is where the action occurs, right? And so we know that sometimes the DNA doesn't get photocopied. So we actually are looking at both the DNA and does that mutation get what's called translated into an RNA, which makes the protein. And so those things they will be standard of care, just like you getting an X-ray. They'll be standard of care within years. New therapies, like I think that when I was in practice, my first 20 years, 13 new drugs got developed. Last year, 43 got developed. And so because we have that basic understanding now, we understand much more how to treat those individual cancers.
You mentioned that the first time we sequenced the human genome, it took 10 years to do that, and now you can sequence a person's cancer, the entire genome, in 2 hours. How does that play into developing our mRNA vaccine that we all think about for COVID?
In the same way, so a virus is very similar to a cancer. It goes in, causes those genetic changes to happen within the cell. They can get that, what used to take us years to be able to detect what was going on in the cell, now can be done in hours to minutes. And so as soon as that infection occurs, we can actually sequence it and know exactly what's going on. And that helps lead to our ability to make a vaccine as quickly. I mean, I think the first vaccines took years to actually make, but to be more predictive, to make our RNA vaccines and the other adenoviral vaccines that were used to actually treat COVID. So it does apply to other things other than just cancer, our ability to really rapidly look at those building blocks that cause many of the changes that go on in a cell.
It's just incredible, the explosion in technology in our careers.
In our career,
yeah.
How would you know that you're going to be doing a lot of genomic medicine?
Would not have guessed.
Yeah.
Would not have guessed, and I imagine you wouldn't have either.
I wouldn't have either. In fact, that I'd have to know,
yes,
much more beyond what the DNA is, but how important it is in our practice.
Yeah. Thank you so much for taking the time out of your schedule to sit down and talk with us and educate our viewers about DNA, pharmacogenomics, and cancer treatment.
Well, thank you. Nice to see everybody.